And Dr. Rajesh Sange, he is the national advisor in this Cornerstone group. And hope everything is okay. Due to this pandemic situation, we are going to conduct this webinar online, but in future, we will also try to communicate with you and call you here in Pune to conduct the webinar or a workshop. Or yes?
Dr. Mahinder is a good friend of mine.
Yes. So he's my student. We were at Ravinar Physiotherapy College, Savangi Mege, Wardha. And what I can say, not a student, but he is one of my family member only. So,
that's great.
Yes. So we always take advice from him, and he suggested your name, and we are very thankful to you that you have spared your precious time.
It's an honor.
Yes. Thank you so much.
It's an honor for me also. And definitely maybe we remain connected in future also.
Yes.
You never know.
Sure. Yes.
Okay.
Always. Yeah.
Shall we start?
Yes. Shweta?
Yes, ma'am. Yes, we will.
Yes. Please go for the introductory portion.
Am I audible?
Yes,
you're audible. Yes. Good evening, all. I'm Dr. Shweta Ambir. On behalf of welcome you all. I hope you're doing well in this pandemic situation. Our organization will brush up our knowledge on lumbar instability. Before for this session, I'm glad to introduce our prominent speaker, Dr. Vivek Chauhan, sir. Before starting this session, Dr. Vivek Chauhan, sir, is an associate professor at Department of Physiotherapy, Dolphin Institute of Biomedical and Natural Sciences, Dehradun. He has completed his Musculoskeletal Postgraduate Institute, Dehradun. Dr. Vivek organized many workshops and has done boundless physiotherapy services in his career. Sir, neurological cases. To have you for this session. Over to you, sir.
Thank you, Shweta. And namaskar and hello, welcome to all for this today's session. And everyone knows the topic for today is segmental instability. And before initiating and going for the topic, I would like to convey my heartfelt thanks to all the organizers, this all young guns of this organization, A.I.S.O, All India Student Organization. That is Dr. Shweta Ambir, President, whom you heard right now, Dr. Renuka, Dr. Ismaha, Dr. Nafisa, and Dr. Haji Ismail. He is the person who is in contact with me and he's helping me a lot. Dr. Divya Thakur, Dr. Prachi, and the team members, Dr. Shruti, Dr. Iram, and Dr. Aishwarya. Thank you all for today's event. You all made it possible. And lastly, the most important people, the advisors, and the main core of this organization, Dr. Sucheta, Dr. Rajesh, and my good friend and my brother, Dr. Mahinder Yadav. I'm very thankful to all of you and wish you all the best for in future core also. And I'll try my level best to convey my best of knowledge today and share the things, what I know with all the participants today. Okay. And see, today's topic, what I am taking is, when we decided with the core team, that is segmental instability or lumbar instability. Segmental, why we are taking to the whole spine today. as example. And we all know the low back ache. Low back ache is the one of the commonest condition which physios or not any people they are suffering from. And physios, they are taking in a lot of cases of low back ache. Today, I'm basically focusing on low back ache. So don't get confused with the irradiating symptoms or any other symptoms. I'm just focusing on the low back ache. It's the commonest condition we are taking. And mind it, when we are taking up the low back ache case, all the physio, they are maybe the final year students, master students are there, clinicians are there in this webinar, or whosoever is hearing it. I would like to say that the first thing is you are treating it. The first thing is what we always, not always, but we know it maybe because of any reason. We just ignore, or being an ignorant, we just go directly for the treatment. If you follow certain protocols of the physical examination and testing, I assure you that the patient will be never returning to your clinic for another 10 years. And take it as a good sign. It's a good sign. And don't think if he's not returning, that's a bad thing. If he's not returning back to you and he's going with a happy smile, coming with a bad smile, it's a boon for you. Now, coming to the today's topic is, we say lumbar instability. It's a self-explanatory word. Lumbar, we are talking about the lumbar segment and instability. Now, it has been a wide topic since 30, 40 years, and it has been, and our theme is also today is evolving concept. Why we kept it as an evolving concept? Because it is still evolving. New findings, new research work has been done on the instability part. So if I discuss what is instability, we'll say, if I consider it as a spinal segment, and here specifically a lumbar segment, we'll take instability as the hypermobility. What I'm talking today about low back ache is hypermobility. I'll say hypermobility or increased range of motion between the two segments of the spine. Fine. I'm here discussing increased range of motion of the segments of the spine. Maybe L1, 2, L2, 3, L4, 5. They are all increased. And if I take a quote of American Academy of Orthopedic Sciences, what they have found out, and they have given a definition, that it is an abnormal response. It is an abnormal response to the applied loads, which is characterized by motion, beyond the constraint, beyond the normal constraint. Okay. So, for example, if we have to go, our spinal segment has to move, just has to displace by 1 centimeter, but it is moving beyond the normal constraint. That is 2.1, 2.2. That is high. The segment is hypermobile. Fine. Now, if I take instability and a lot of research work, I hope master students are there and practicing clinicians are there. If you go through, the instability is divided into two parts, and it is a research based. It's not me saying it has two things, but it is a research based and firmly said it is of two types, that is functional instability and mechanical instability, which we sometimes ignore. Now, if I talk about functional instability, which is the most commonest of the instability in the low back ache patients, that is, it is because of the loss of neuromotor capability, leading to the abnormal control of the segmental motion. I repeat that there is loss of neuromotor control capability to control the segmental motion, or there is abnormal segmental motion because of loss of neuromotor capability. If I talk about mechanical instability, it is all because of there is any injury or any loss of passive stabilizers of the spine, which is again leading to the abnormal motion, and that abnormal motion is during the mid-range. Fine, I'm very clear with the two things. That is functional instability. Mind it, remember it. Those who are hearing it, if you have do keep the notepads and pen with you. Hearing won't help. If you note it down, it will be very fine for everyone. functional instability and mechanical instability. Now, how these two things, if we talk about functional, we have quoted that there is segmental instability, lumbar instability. Now it is of two types, functional and mechanical. Functional will set neuromotor control loss. Mechanical, there is normality in the passive stabilizer. Okay. Now, it has been research-based fact, and it has been established or a established fact that our spine is controlled by, our spinal segment, it is controlled by 3 subsystems. I'm repeating, our spinal segment, all the motions, they are controlled by 3 segments. That is, if we take it as a triangle, the topmost part is passive subsystem. Topmost part is passive subsystem. One is active subsystem, and the third is neural control. Fine. Passive subsystem, active, and neural control. If I talk about what is passive subsystem, passive subsystem is, it comprises of all the ligaments, intervertebral disc, facet joints, and capsule. Remember it: ligaments, facet joints, capsules, and the tendons. Active subsystem, it comprises of spinal muscles and the thoracolumbar fascia. Active subsystem, it is comprising of 2 things, that is spinal muscles and thoracolumbar fascia, and neural control, obviously spinal nerves and the central nervous system. Now mind it, any problem in either of these systems, any problem in all these subsystems will hamper the other 2 subsystems. If I say, if there is neural control problem is there, obviously active and passive subsystem will be hampered, and vice versa, any of the subsystems. So these 3 are interdependent, and it becomes a prime importance thing for all the physios, for every one of us, to look out when you examine a patient or you take a history of a patient. All these 3 subsystems, we have to look out which of the either of these subsystems has been hampered. Okay, so we talked about, and these 3 subsystems is the reason for any abnormality in either of these leads to mechanical instability. I said because of passive stabilizers, and I said functional instability, that is because of neural control. I hope you will understand. Now, before progressing further, I want to see why today I just want to clear the base. And if you understand the basic, we have 2 zones in the body during the motion. I'm talking about the spinal motion. Definitely you might have studied through your bachelor's or in your master's, or maybe otherwise you might have heard in any workshop conferences. They might have told you and you are aware. I'm just repeating it, or we are revising it rather. We have 2 zones, which is the most important thing. And whatever I'm talking again and again, I'm repeating, is all research-based, evidence-based. That is neutral zone and elastic zone. Fine. If I talk about neutral zone, see what is neutral zone? It is a physiological range of intervertebral motion in which the motion will occur with little resistance. For example, see, I'm sitting. I'm flexing my spine. Fine. This is my normal physiological range with less of the resistance. That is my neutral zone. That is 10 to 20 degrees of flexion. Neutral zone. That is occurring between the segments of the spine. If I talk about elastic zone, what is elastic zone? Elastic zone is beyond the neutral zone. Fine, it is beyond the neutral zone, and it stops at the end of physiological range of motion. Fine, I said in neutral zone, this is the flexion, 0 to 10 degrees, 15 degrees with the minimum resistance. Now beyond this neutral zone, it will go beyond. I can flex my spine further and it stops now. This is my end of the physiological range of this spinal segment. Fine. Hope you remember one term, lumbopelvic rhythm. Now the further movement, since my pelvis, I am sitting, my pelvis is stabilized, so further flexion is not possible. So my physiological range has stopped. So this, where the range where the physiological range stops is known as, this particular zone is known as elastic zone. So now for the physios and any patient, these are the two zones which the patient will be complaining. For example, आपके पास patient, he can come to you, he say, Doctor साहब, whenever I am brushing my teeth, जब मैं brush कर रहा हूँ, I am having a pain at my back. Fine, just a normal. You never flex your spine 40 or 50 degree for to brush your teeth or for to have a face wash. Fine. Or when you are having a meal, you are taking up you're bending forward, you are having a pain. Now from this thing, you can diagnose in a patient whether the pain is in the neutral zone, that is in the normal physiological range. Fine. Or if you are bending further, the patient is bending further, the pain is in the physiological range. That is the end of the physiological. The last, matlab, the vertebral segment has displaced further. So we can diagnose from here that there can be hypermobility at either of the range, maybe L3-4 level or L4-5 level, if it is in the elastic zone. If it is above the vertebral segments, the problem may be in the neutral zone. I hope you are clear with the 2-3 things, the subsystems and the zones. This is the most important thing which the physios has to diagnose if you want a permanent cure for your patient and a very good smile when he goes off your clinic or your setup. So if again, now this is just one of the 2 or 3 parts of the mechanics of the physiology. If I go how the, if I'm saying about, I'm talking about subsystems, I'm talking about the zones. Now these two things, they are primarily governed by, which is, or maybe supported by, rather I'll say, by the structures, the muscles. Those muscles are known as local muscles and the global muscles. Hope you are aware of these terms, the local muscles and the global muscles. So what are these local muscles and global muscles? If I tell you these are the local muscles, definitely, oh, these are the local muscles, we knew it, but we never knew it, these are the local or these are the global. See, local muscles are, they are the deep structured muscles. They are the deep muscles of the, in the spine. Fine. And they are primarily responsible for the segmental stability. But my point, these local muscles, they are important for the segmental stability, and these are transverse abdominis and multifidus. But my point, and same way, the global muscles, these are the superficial muscles. They are responsible for the rotational segment, rotational mobility of the spine. Fine. These are erectus spinae, rectus abdominis, and the oblique muscles. So all these structures, if whenever you are assessing a patient of low backache, you have to go for the assessment. You should know the strength of these muscles, the action of these muscles, and the mechanics of this muscle. Now, if I talk about why these muscles are important, if you remember the origin and insertion of transverse abdominis, what happens is transverse abdominis, it will act as a canister. It will act as a canister. It is transverse abdominis is there. It will act as a canister with the diaphragm and the pelvic floor muscle. It is acting like this. Fine. Acting like this. What will happen is whenever the transverse abdominis contraction will be there, it will uplift the diaphragm as well as the pelvic floor muscle. Fine. If you understand the term canister. So what will happen is it will increase the intra-abdominal pressure, and this muscle will decrease the intradiscal pressure. Okay. See, I'm in a sitting position. If I contract my transverse abdominis, if you all are sitting position, what you do is just tuck in and raise your chest above. What will happen is immediately when you tuck in, what will happen is your spine will extend. So that is the action of transverse abdominis. Fine. Same way, there is multifidus. Multifidus is responsible. It is, see, if you remember the origin and insertion, multifidus is coming from the PSIS, the sacral part, and the posterior sacrum, and inserting along the spinous process right from L5 to C2. Fine. So along the spinous processes. So this particular muscle, it is responsible for the rotational stability of the spine. If I am sitting, you people are sitting, if I have to turn here and there, if I have to look here and there or rotate, this muscle is responsible for rotational stability. Fine. Am I clear with the local muscles? If I talk about global muscles.
Hello.
Yeah.
Sir, firstly you told like TA and multifidus is local muscles.
Kindly mute your.
Hello.
If I talk about global muscles are the superficial muscles. Fine.
Sir,
Global, these superficial muscles, I told you, they are responsible for the rotational stability, and they are rectus abdominis, erectus spinae, and the obliques. Along with the rotational stability, what they are doing is they are basically generating the torque. It is generating a torque to control the spinal orientation. Rectus abdominis, it's again abdominal muscle. It is generating a torque to check the spinal orientation. Fine. And because of the co-contraction of these muscles, fine, of erector spinae, rectus abdominis, and the obliques, there is control of the spinal motion when the external forces or a load is applied. When there is external forces or load is applied. So together, now you must remember this thing, why these two muscles are important, both the local and the global muscles. Global muscles are acting when there is external application of the load. Okay? For example, if I am lifting a weight from the ground, I am taking up the bucket, or I'm for in the marketing people, they are carrying up a suitcase, or if you are carrying up a bag and you are climbing upstairs and downstairs, this rotational stability will be maintained by the global muscles because they are acting in a co-contraction. Is that clear? Along with the local muscles. So any problem in these two groups, either of the group of the muscle, is responsible for hypermobility because they are attached along the transverse and spinal process, will lead to the problem in the spine. Fine? Or the low back ache. Now, if I talk now, what are the basic causes of this lumbar instability, which we all are aware of? There are a lot of, this is just a theory part, there are a lot of degenerative diseases along the spine. If I talk about facet joint hypertrophy is there, and commonly the most important reason for hypermobility is the post-operative reasons, and the abdominal incisions are there. Now the young ladies, they are coming after the C-section, they are complaining of low backache. So no one go for the diagnosis of all these segmental things or this muscle group, but you are all following for the traction, hot pack, mobilization, manipulation, but no one is focusing for all this global or local muscles. No one is trying to look after the subsystems. Any ligament is injured. Once the spinal anesthesia is there for the C-section and all, it has led to the problem in the spine. And if I talk about, there can be the developmental disorders, congenital disorders, or any infection to the spine leading to the any damage to the ligament. See, if I'm talking about here, if I'm talking about instability, please remember one thing: passive stabilizers. We have talked about active subsystem, passive subsystem, and neural. The passive subsystem plays a major role. Where I talked about that the ligaments and tendons, they are working together. If you remember the anatomy, we have the supraspinous ligament, interspinous ligament, intertransverse ligament, and ligamentum flava, which are visible. Ligamentum flavum is visible along the spine. You all go for the, if you go for the scanning, MRI scanning, everyone is focusing towards the disc space. No one is focusing on the ligamentum flava. Any inflammation, any problem in there is definitely going to hamper the system or the segmental motion of the spine. So you need to focus there also. Okay. I hope so I'm clear till now. Now, if I go further, we talked about subsystem, we talked about zones, we talked about muscles and their role. Now, what will be the presentation of a patient if he comes to you or when you go for the objective examination? Or what will be the patient history? Patient commonly, what we'll say is he is having a catch feeling, a giving away. What he says is, when I get up early in the morning, when I just get up and try to stand up, I have a feeling of catch. Or a lady is working for a long time in the kitchen or going for a catch. Suddenly there is a lock. Okay, so that is again a patient is unable to extend, because again, if you remember, our global muscle, erector spinae or transverse abdominis, our local muscle which helps in its extension, is not working. Fine. Same way, patient can say there we are having a hitch at the moving segment. We are having, whenever we change a position. For example, some people, they are sitting for a longer time. Nowadays, everyone is in lockdown. Either you people are lying, we all, not you, we all are either lying down or we are in the sitting position. That means the recumbent positions are there. Whenever there is a complex motion, when you have to accompany flexion, extension, rotation, there is a problem again. And localized pain is there. And one more presentation will be there. Just as I said, for the feeling of catch, you go for a gower sign, GOW, a gower sign, where patient says whenever he or she is standing from sit to stand, he is having pain. And whenever she sits down, there is no pain. She or he sits down, there is no pain. So this again shows a sign of hypermobility is there. The mechanical receptors, the pain receptors are activated, and sense of pain is there in the low back region. I hope so I'm clear with all these things. Then you go for the differential diagnosis. Differential diagnosis is a major part. जैसे अभी मैंने ये कहा sit to stand. A lot of you will be there. It can be piriformis syndrome. Remember it, piriformis syndrome has a localized pain in the buttock region in the deep, and it may mimic sciatica, as a referral pain along the posterior thigh. Fine. So there is no relation. You have to go with the differential diagnosis of a lot of things. You have disc herniations can be there. You have to exclude disc herniation. Here we are talking about lumbar instability and low backache. So no herniation will be entertained. Any facet syndrome is there. Osteoporosis is there. So we have to go with a detailed examination. Fine. Then before progressing forward, I hope so, master students, if they are there, and if the clinicians, you are hearing me, I would request you people, when you have such patients, and this is the basic drawback in our society, in our, what I'll say, in our profession, I'll say, everyone is going for a treatment, everyone is seeking a treatment and for immediate relief, but no one is going for the data compilation. I would request you people, if you go for the data compilation along with academics, you will be of great help, not only for yourself, for the patient, as well as whole society also. So there are, for the students, for the final year students, you can go for your project work. Master students, you can go for a project, and clinicians. See, I'm not going in advanced things, and I'm trying to compile all this topic in the simplest form. I would request everyone, if there are certain outcome measures to take care of, if you can do either of the subjective examination of the patient without touching, just you can three scales with us. That is, we have Oswestry Disability Index. I think a set of questionnaire activities of daily living of the patient. Fine. And he has to perform, and according to the score, you can correlate what problems he's having. Maybe certain patient, maybe language barrier is there, maybe the patients are not expressive, but through this questionnaire, you can just have a subjective examination. Or the objective rather, will say a patient word will be there. A patient is able to, you will be able to diagnose the complexity the patient is having in the ADLs. Oswestry disability index is there. Same way we have Quebec, Quebec, Quebec pain questionnaire is there. A disability scale is there, in which you can diagnose the functional disabilities leading to the low backache. This scale is totally performed on the scoring based performer is there, where the patient is having certain functional disabilities leading with the low backache because of the low backache. And last, the Rowland-Morris disability questionnaire. Rowland-Morris is there, which is the physical disability due to low backache. If you follow these three questionnaires, this will help you a great deal to assess and diagnose a patient for the instability. Okay? Hope so I'm clear till now. Am I going fast? Please let me know. I'm going fine.
Yes, sir.
Okay. If I go for now, see that this is all part we are assessing clinical presentation and all. Now, if you have to go for the physical examination of a patient, this plays a now major role. Now, the patient is you have to go for the examination. Fine. Now we have a low means particular sign is there. We call it a low midline cell sign. What is happening there is low midline cell sign. We have the vertebra here. When you will palpate along the spinal column, when you palpate along the spinous process of the patient, right from thoracolumbar junction, and you go down, there will be the increased lumbar lordosis of the patient. One thing, there will be increased lordosis and with the formation of capital L sign. Fine. L sign will be there. For example, if you see this vertebra, if you are going along the spinous process, right from the thoracolumbar junction, you are moving downwards along the spinous process. What will happen? This spinous process will be slightly tilted. The superior vertebra or spinous process will shift anteriorly the below spinous process, forming a L sign in the midline. If there is increased lumbar lordosis and with the L sign is there, that is a clear positive sign for the instability. Fine. Now, this is the one part, the one palpation part. Second thing is, most important thing is, that is, if we are talking about hypermobility, it becomes very important to know which segment is hypermobile, L1, 2, 3, 4, 5. Now, and it has been previously, almost 3-4 decades earlier also, Schaub method was followed. Schaub method was followed, or we call it a tape method. What we do is, we mark a point on a bare spine, bare back. We mark a point at this is the bare spine. L5 is there. At the lumbosacral junction, 1 point is there. And from that lumbosacral junction, 10 centimeter above, 1 point is fixed. Fine. We measure it with the tape, the normal range, whatever the range may be there. Maybe 6 centimeter, 7, whatever. The 10 centimeter range is there, fixed. It is a fixed thing. Fine. Now we ask the patient to flex. Initiate the movement, flexion through the neutral zone. We'll ask, just bend forward and you measure the range. Fine. Then we'll ask the patient to flex further. Then we note down the range again. Fine. The difference between that range, maybe, for example, we had a range from lumbosacral junction, we marked it 10 centimeter above. Now the patient is flexing above 1 centimeter. Is fine. If you ask to go beyond to its normal limit, pain-free, he bends more to the 2 or 3 more centimeters. Right? 12 centimeter or 13. That means the difference comes out to be 2 to 3 centimeters. So that is the spinal. Then we'll go for the proper assessment of the intersegmental motion. This particular tape method or Schaub's method, which we known as modified Schaub's method, is being practiced, in which the patient, if you remember the lumbopelvic rhythm, we said that there is spinal segment motion is there, but along with that spinal motion, the pelvis also moves forward. Pelvis also moves forward. So what happened is, what they do now, what we practice is just 5 centimeter below, 5 centimeter below the lumbosacral, this L5A, 5 centimeter below the lumbosacral junction. From there, we draw a line 10 centimeter above. Fine. From there, from lumbosacral junction, 5 centimeter down, and from lumbosacral junction, 10 centimeter above. So total 15 centimeter length is drawn. Now we check with the 15 centimeter, then we ask the patient go for the flexion movement or position. Fine. Now, same way for the lateral flexion. Lateral flexion, you must be all aware of. We ask the patient to laterally flex towards the ground and amount of range, any physiological range he is going in the pain-free motion. We measure it from the tip of middle finger to the ground. We are measuring it. Clear? That is for the lateral flexion. Now comes the major part. Now you measured and you came out with the difference. Now, if you're smart enough and your hands, what I always say that our physio hand is an eye. This is, we have, okay, thank you, Himani.
Yes, sir, you can continue the
Okay.
session.
Now, after diagnosing all these things, now if we, I was very much saying that our hands, we have got the God-gifted eyes, but if you want to be a successful physiotherapist and if you want a good result out of you, this hand should have an eye. This is your eye. Okay, you can become the Mahadev of physiotherapy, a third eye. Fine. What is there? A third eye. You have to feel this spinous processes. For example, see, this is L45. We have to palpate the L45 same way, L1, L2, or L2, L3, then L4, L5. Find these two segments. If I am fixing over the L45, I am keeping my fingers over L45 and I'll ask my patient to flex forward. I have to see the how much displacement is there of L4 vertebra over the L5. Same way, L4 over the L3, L3 over the L4. Same way, L2 over the L3. So you have to have that palpating and guiding hand to see how much the patient has displaced. And if you remember, we had a clinical presentation of a patient of saying whenever he is forward bending, he is having a pain. So we'll see which segment during bending is creating the problem. Fine. Then we have sit to stand test is there that we already talked about in the. This is, see, I have today I have prepared myself with the easy method to diagnose a patient. There are a lot of tests for checking the instability, but I know in the clinical practice, to perform all the tests is not going to have good with the patient. Sit to stand test, as I said in the clinical presentation, what will happen is patient is sitting in the chair, he's having a pain while coming down from stand to sit. For example, I'm sitting, patient is complaining of pain. The moment we'll ask him to stand up, the patient is relieved of the pain. So, and that is a common symptom. The patients those who are not having any irradiating symptom, the radiation is not there, and they have a localized pain, we always go for mobilizations. We go. And let me tell you one thing, without assessment, if you are going to mobilize that particular segment because you have learned somewhere, you have to go for mobilization, you have to go for manipulation, or you have to go for deep fitting modalities. Maybe, mind my words, you go for a wrong treatment, a segment which is already a hypermobile segment. Here we are talking about instability, a fragment which is already unstable. With all your different techniques or hi-fi techniques or whatever tools you are using, you are again, instead of giving him some relief, you are increasing the pain. Momentary, he get a relief because of all the deep heating modalities and all the manipulations you are doing. But he will definitely come next day of complaining more of pain. If not next day, in a long run, the severity of the segmental motion or pain will be more. So if you go with the proper assessment, I am not saying don't go for mobilization or manipulation. Go with the proper assessment. And segment which requires mobilization, go for it. Segment which requires manipulation, go for it. But without any assessment, a segment which is already hypermobile, never go for all these things. Fine. So assessment plays a major role. Now the basic things. If you are a trained physio, again, eye in your hands, we go for PAIVMs. That is passive accessory intervertebral motions. PAIVMs. Passive accessory intervertebral motions, in which the patient is in the prone line. Again, the lumbar segment is exposed, and with the pisiform bone, you apply. This is the spine. If the patient is in the prone, you are applying a pressure over the spinous process. Fine. You are applying the pressure over the spinous process with both the hands. See, if it is stabilized, you are focusing here, and you are applying the guiding force. Your guiding force is pisiform bone. Here you are going for the accessory motion or accessory glides, that is PA glides, posterior to anterior glides. Here you are checking the hypermobility of that particular segment, maybe L4, L3, L2, L1. Passive intervertebral motion. Not only the segment will be hypermobile, the patient will be having a localized pain. The patient will have the apprehension. The moment you apply over it a pressure or slight overpressure and you give a slight glide, the patient will complain of pain. And what you'll experience is hypermobility. So you have to go for PIVMs. Fine. Now, if I talk about another thing is PPIVMs. That is, this was passive accessory intervertebral motion. If we talk about it, that is passive physiological intervertebral motion. Fine. It is again a simplest thing. You ask the patient is at the end of the couch. A couch is there, end of the couch, and his upper trunk, upper portion of the spine is supported on the couch and lower half is hanging downwards. Fine. What will happen is you are again palpating the spine, and the patient is, you will apply the PA pressure. Again, you will apply the PA pressure. Once you diagnose that particular segment is hypermobile, you will apply the pressure of that slight gentle pressure, a PA glide, a posterior anterior pressure will be applied, and patient will complain of pain. But when you'll ask a patient to lift his legs up or isometrically contract the spine, go for the spinal isometric contraction, patient will be relieved of the pain. So when there is relief of pain after that PA glide, that means the test is positive, permanently positive for hypermobility. Am I clear with this thing? Last two tests which you can perform, either of these, I'm not saying you have to follow all these tests, sit to stand, intersegmental, everything. You have to, intersegmental, yes, you have to go for the segmental motion, you have to palpate. I am giving you the choices. Whatever your patient can, you can go for the assessment of a patient. And we have the prone instability test. What is happening? Oh, sorry, PPIVMs. Oh, sorry, I want to repeat PPIVMs. That is passive intervertebral motion. It is in the sideline motion. That is in the sideline motion, in which the therapist grasps the hip and the knee, and he will flex. He'll go for the flexion and extension motion along with the palpation of the spinous process. I was sorry, by mistake I took it for prone instability test. In PPIVMs, passive physiological intervertebral motion, the patient is, you will be holding on the hip and the knee, and you will go for the spinal motion towards the flexion and towards the extension to check the intervertebral motion. In the prone instability test, what I told you by mistake for the PPIVMs, that is in the PA glide, there will be the pain, localized pain, and when the patient is asked to extend the leg or go for the isometric contraction of the spine, the pain is relieved. That is prone instability test. If the pain is relieved, the test is positive. Lastly, we have the passive lumbar extension test, which is most important and easily performed. Patient is in the prone line, and you'll ask him to extend both the hips or both the legs, extended knee, ask him to both the legs to 30 centimeter of the length. If the patient is having a apprehension or localized pain at a particular segment, That is because of the hypermobility of that particular segment. See, these tests, you can prone instability test or the passive leg extension test, you can practice on the sportsmen. Now the sportsmen, they are coming with a lot of low back aches, maybe a runner, jumper, thrower, or maybe a sportsman with a contact sports, rugby, boxing, kabaddi. Now they're all into sports. You can go for in those people, the hypermobility is one of the major reason for low back ache. So you have to go with the correct examination of this hypermobility. So for all these people, prone instability test and the passive extension, leg extension test plays a major role. I hope so I'm clear with all these things in the instability. Now, lastly, if I have to go for, जब ये सारा हमने ढूंढ लिया, what will now what is our focus? Our focus is strengthening of these muscles. Fine, our local muscles, I told you, that is multifidus and transverse abdominis. Global muscles are rectus abdominis, erectus spinae, and external obliques. So I'll tell you the 2-3 basic exercises. The time is limited. I'll talk to the organizer sometime if possible in next webinar. I'll go for the live demonstration of all the physical examination and all the strengthening exercises. But verbally, which is possible, 2-3 exercises which I can tell you for the strengthening. I'm telling you, when the patient is, first you will follow all the protocols of spinal isometrics, hip strengthening exercises and all. Once you find out the patient is capable, and if the test you conducted, they are negative now, for example, prone instability is negative, your lumbar extension tests are negative, then you will go towards the strengthening of all these things. Now, if I talk about multifidus, you will go for the multifidus strengthening, which is the most commonest. Along with, when we are talking about the multifidus, it is these exercises. If you remember, in the all four position, in the prone kneeling, in all four position, what will happen? We'll ask the patient to tuck in, inspire, inhale, and tuck your tummy in the all four position. And simultaneously, the moment you inhale, lift your one leg or extend your one hip and the knee. That is, for example, if you ask the patient to extend your one hip and knee of the right side, right hip and knee is extended, simultaneously just abduct your left arm. That is known as bird dog exercise. Fine. This is basically for multifidus and transverse abdominis. Fine. Bird dog exercise, I repeat, in the all four position, you inhale, inspiration will be there, and the moment the tummy is tucked in, you ask the patient to extend the hip and the knee. For example, if it is the right side, the moment he extended, simultaneously you ask the patient to abduct the left leg. That is the bird dog exercise. Or you can go for what we call it, one arm push-up. One arm push-up. That is very simple exercise. I'm telling you the simplest exercises before going towards the advanced exercises. One arm push-up is one hand will be behind the back. Patient is leaning towards the wall with a straight arm. Fine. Legs apart in the anatomical position, standard position, and one arm position is there. And you ask the patient to move forward, not bend the spine. You have to, it is fixed, and you move forward and backwards. Fine. This is just initially the patient is close to the wall. Initially the arm distance is close to the wall. Slowly and slowly we can increase the distance. Same way we can ask the patient to bend down towards the stool, towards the couch. Keep the hand there, place there, one arm behind the back, and move downwards. Then come up. Then move downwards, then come up. If you are focusing on the erectus spinae and the muscles, if I talk about global muscles, patient complain kya tha? In the physiological motion there is problem. You can ask for the deadlifts. Now here we are not training, we are not going for the weight trainings, or we'll ask the patient to lift a heavy weight. Before going for the deadlifts, you will measure the RM, any difficulty, maybe it's 5 kgs, 7 kgs, 10 kgs, you keep the weight downwards, a barbell is there, dumbbell is there, or a rod is there with some weight. Ask the patient to bend down to the knee and lift it up and extend the spine. Inhale. The moment you go down and come up, inhale and lift up. That is a deadlift. Okay. You move down, come up towards the hip level. He has to carry up the weight till hip level and extend the spine. Basically, you are training here the erector spine. Fine. And the transverse abdominis as well. Fine. Same way, lastly, we have the Superman exercise. This is the simplest exercise. Patient is in the prone line. Fine. And you ask the patient to extend both the arms and simultaneously extend both the legs. Fine. Extend both the arms and extend the leg. Here you have to be very smart. See, in all these exercises, a physio has to be very smart enough, since you have diagnosed a problem at particular lumbar level, L1, 2, 3, 4, 5. Whatever extension you are asking to patient to perform, it should be specific to that particular. If I am saying go for the Superman exercise, ask him to extend, immediately extend the upper spine and extend the hip. That extension should be segmental specific. Same way, deadlift, when the patient is coming up and you are asking him to go into extension, it should be segmental level. L3 level, slight extension. L4, go beyond. L5, go beyond. So you have to be very clever with all these exercises. Same way, bird dog exercise, same way with the one arm push-ups. So that's all. I hope so. I am able to justify the segmental instability. Any queries, please let me know.
Sir? Hello? Am I audible?
Yes, you are audible.
Sir, actually, Dr. Himani had a question about SI strain. If Himani is there in... sir, actually, Dr. Himani had a question about SI strain. So if Himani is there, she can directly ask the question to sir.
Yeah.
SI strain. Here we are basically talking about lumbar instability.
No, sir, I don't have doubt about SI joint.
Okay.
Actually, this I have written for a differential diagnosis. My question is, you told like local muscles are which are responsible for the segmental stability. This is TA and multifidus. And global muscles are for rotational stability. And sir, further you told about TA, function and action, and multifidus. Then you said like multifidus is for rotational stability. So
Okay, I got your point. Listen. What I told during the session, if I'm talking about the local muscle, if you remember, I said in local muscle, if I talk about this transverse abdominis and multifidus, okay, multifidus, it is rotational. If I am talking about rotational, that is not absolute rotation. If there is conjunction, see, when we are talking about spinal rotation, it is not one muscle responsible for the complete rotation.
Yeah.
Remember this thing also.
Yeah.
If that rotation is initiated, basic function of multifidus is what?
Yeah, rotation.
And what is the basic function of the rectus abdominis and the, if I talk about the obliques? They are taking up the rotation. If I talked about global muscles, I said when the external load is applied, if you remember.
Okay. Yeah. Yes.
I said when the external load is applied, maybe you are carrying a bag, you are lifting down, you are picking up the bucket. At that time, the rotational component which is taken up by the global muscles. If I am sitting, I am rotating. This is local muscles without any external load. Got my point?
Okay. Yeah.
I'm lifting now. If I am sitting and I have to lift an object of 5 kgs or 10 kgs and I am coming up, rotatory motion is there from the left side.
Yes.
I am coming up.
Yeah.
This action has been taken up by the global muscles.
Yes.
Now you got my point. When there is the external application is there, load is there. So don't get confused. That's what I said. When the patient is complaining कि जब मैं बाल्टी उठाता हूँ तो pain होता है. एक पेशेंट की कंप्लेन क्या होगा, when I'm brushing my teeth there is a problem. That means brushing local muscles, lifting up a bucket global muscles.
Global muscles. Yeah.
Are you got
That
my
means
point?
it's further rotational forces are added there
Yes,
for
yes,
global.
yes.
Yeah. Thank
in
you
the
so
global.
much, sir. It's really very interactive session, sir. Thank you so much.
So I think that
See,
was
before we
the.
have some time for interaction, any other queries, I will try myself to clear it out if there is any
So
query.
please arrange one session with practical. Like, I
Yeah,
really
that
would
is
like
more
to.
important. First thing is, see, my objective today was to clear the basic.
Yeah.
If the basic is clear, we can go for the practical session.
Yeah. Thank you so much.
I don't have to repeat again and again.
Excuse me, sir. Can you hear me?
Yeah.
Sir, you're talking about the muscle strengthening exercises. And is there any exercises to strengthen the ligaments?
No. See, strengthening of ligament is not possible. Where I am focusing main is strengthening of the muscles. Fine.
Yes, sir. It is a doubt for a year together. Actually, I was coming across many situations, and my colleagues were discussing. We were having muscle strengthening exercises. Is there any exercise to strengthen the ligaments particularly?
No. We are focusing. See, if the muscles strengthen, if muscles are strengthened, that will avoid the external load on the ligaments. The ligaments which has become laxate, may be inflamed, maybe any issues or tearing is there, whatever is there. So the load which is transferred from the muscle to the ligament, which are maintaining the spine. See, if I talk about, say, if this part is there, interspinous ligaments are there, transverse ligaments are there. So when, for example, 100 Newton force is there, that force, if the muscles are weak, that particular 100 Newton force is distributed along the ligaments. So that ligament which is already injured or laxate or stretched, that has to bear that particular force. Since if our muscles are strong enough, what I told you, if you remember in the transverse abdominis, it decreases the intradiscal pressure. So that is the thing, the load. If I'm talking about 100 Newton force, that force is distributed among, if our muscles, the core muscles, the local as well as the global, they are strengthened enough, less of the force is guided towards the ligament. And basically ligament is what? It is just maintaining the two bones, a joint. Just it is giving the stability. So less of the shearing forces or the axial forces will be acting towards the ligaments.
Yes.
Sir, can I ask one more, sir? Sir?
No, sir. Show me yourself.
Not cancelling.
Excuse me, sir.
Any other questions, please let me know.
Sir, can you please tell me, tell all of us, who is prone to ligamentous stress? Mean elderly patients or the middle-aged patients? Who is more prone to muscle
Please,
stress?
can you be slightly a bit loud?
Sir, can you please hear me now?
Yeah.
Sir, who is more prone to ligamentous strain, whether aged person or middle-aged? Who is more prone to muscle strain, aged or old-aged? How can we judge, expect the thing to diagnose, differential diagnosis?
Oh, see, I'll say the more people on the ligament, if we talk about the sprains and the strains, it is never confined to any age group. If I talked, if you have to go for the clinical presentation, you will see, or I talked about the complaints of the patient. It can be a young age group also. I told females, those who are undergoing the C-section under the spinal anesthesia. I talked about infections. If I talk about a sportsman, they are more prone towards the ligament strain. So age, yes, with the age, I'll say it is one of the criteria, because it's a universal truth. Everyone knows after 30, whatsoever nutrition, exercise, whatever you are taking, the body undergoes, or the bones, they undergoes the degenerative process. It is a natural process. Aging, yes. But if we talk about sprains and strain, it is purely dependent upon the first thing is the postural habits. Second thing is the occupation. Third thing is your lifestyle. That's why, if you remember one thing, in the whole talk, I don't know how many webinars, seminars, workshop or definitely your teachers, maybe in your college, they might have put stressed upon. I said, if the clinicians, they go for the outcome measures, the scales. That's why I said, follow 3 scales, Oswestry, Quebec, and Roland Morris. I'm talking about lumbar. It can be, there are a lot of scale and questionnaires for the shoulder complex, elbow, hip, knee, ankle, every joint. Here, you will be talking about ADLs. Here you will talking about functional disabilities. Here you will be talking about physical disability. That what we have to diagnose. Yes, age relates to a common sprain and strain. I agree. Degenerative procedures are there, and if you remember, there is the problem. There is what we call it fluid. The fluid content is reduced. The synovial fluid content is reduced. The cartilage destruction is there. The neural receptors, they are getting more pain. So that can lead to pain. But if you talk about instability here, if I am talking about instability, forget about ligamentum sprains and strains. That is purely upon the postural habits, your occupation, and your lifestyle.
Yes, sir. Sir, with thanks for the excellent explanation for all those things, sir. Small things, and by practice only we can be getting clear of all the doubts. And
my objective today is to clear the base, to make a base for all the youngsters, young budding guns, and especially these organizers. I was very happy to see them. They are very, I'll say them, they are young guns who are trying to do something good for the society. And we here, maybe me or anyone whosoever comes for the webinar, I will never say we are full of knowledge or complete atlas of any topic. No, it will be wrong on our part. Whatever knowledge or whatever experiences we are having, we'll try to assure that we give our bestest to the society and the people who are attending in a simplest way. That's why I took it as a lecture formation. I didn't go for any PPTs or any, I could have gone for directly test and treatment also, giving a live session, no. But once, I hope so, today the base is clear. Next time when we'll go for the, if they allow, the organizers allow me, we can go for the live sessions. At that time, the whosoever is participating here, it will be easy for them to remember and go for the treatment part. Thank you.
Yes, sir.
Yes. Dr. Mahendra has joined, I think so. And Dr. Rajesh is also there. Dr. Mahendra?
Yes, ma'am. Good evening. Hi,
yes,
sir.
good evening.
Good evening. Good evening. कैसे हैं सर?
Yes.
Oh, you are all loaded. You are all loaded.
नहीं, पेशेंट है मेरे साथ, बट मैं बोला नहीं, अभी आप हो तो थोड़ा देखना है इसको. ये मेरा एक साथ ये बच्चा है.
अरे वाह वाह.
Say hi.
Good. Hi.
ये मेरा पेशेंट है सीपी का, और लास्ट अराउंड 6-7 मंथ से मेरे साथ है. पहले भी ये बैठ भी नहीं पाता था. अभी ये he is walking.
You are in a very good and safe hands. बस जो अंकल, जो डॉक्टर साहब कहेंगे, अंकल कहेंगे आपका तो अब अच्छा बॉन्ड बन गया होगा. जस्ट फॉलो व्हाटएवर.
नहीं आती, हिंदी नहीं आती. He is Arabic guy. पकड़.
हाँ तो बता देना.
but he sing the song, हिंदी song. ये मेरे साथ रह के हिंदी सॉन्ग सीख गया है. पकड़, can you sing the song?
Good. Very good.
His name is Fakir, so he loved this song of this Fakira Manja. So he think like this song is dedicated for me actually.
Okay. So today's session was very good and very knowledgeable, and doctor has shared the knowledge to the students, or his knowledge to the students, and henceforth we will try to conduct one live practical session webinar from
Yes,
sir
yes, very
side.
soon. Thank you,
Yes,
Vivek sir.
yes,
Thank you.
yes.
Thank you so much
Thank you, sir. Yes.
So
for
thanks to you
accepting
for
the.
listing my name, and thanks to the organizers. I got an opportunity to meet all the good people.
Actually,
And
sir, I'll
I
tell
hope
you, they just
my part.
approached me. I'll tell you, they approached me like all the students, sir. We need someone expert in musculoskeletal. I told, okay, call sir, khalas. So no need to think. So thank you,
Thank you.
sir.
Ma'am,
We'll move ahead, or we have lots of.
Yes, please. Yes.
ma'am, now
Concluding
Renuka.
session.
Yes,
Yes,
sir.
concluding
Yes.
session. And God
So
bless you all.
you must
Dr.
be having
Mahendra, God
feedbacks.
bless you.
Do
Yes.
please send me the feedbacks. It will be good for me. I don't know.
Yes, yes.
Maybe there, maybe it may be wrong, or
No,
it
sir.
will be good for me.
Feedback.
Sir, it was.
Yes.
I'll tell you. I was not in focus, but I was listening you because my patient was also there. It was really nicely you explained, and definitely they are very happy, and they
Yes,
learned
yes.
a lot. And definitely they will say you also feedback. They will write the feedback and they will submit.
Yes, yes. Feedback forms
Yeah.
are there. So we'll share that feedback
But
forms.
it is
Sir,
important
कहने
for
की
the student's point of view.
सर कहने
You
की बात ही
people
नहीं है,
are all
आप बेस्ट हो मुझे पता है, इसलिए
you
मैंने
must-
आप सीधा.
the student
Yes, some
feedback
students
counts.
can comment. If some students want to say something, please share your experience with us,
Any
sir.
student, if you want to say something or you want to share something with me, please
Yeah,
let
it
me
will
know.
be better. Please, some students come forward and just.
Or any student who wants to say something or talk. Anyone?
So, Shweta and Haji, Renuka, please say few words. Come forward and say few words.
Good evening, sir. It was definitely very informative session. You explained everything very well, and I'm one of the organizers from the team, and we would surely like you to have us for the live session, as you said, for demonstrating the assessment techniques and treatment techniques. We would surely like you to be with us for that. Thank you so much.
I want to hear more from the participants also, if it is possible, if they want. As we conclude.
Yes. Students, please speak if you.
Sir, I think all the students are so silent because you are so knowledgeable and they can't express their feelings just like that.
Oh,
Thank you for a good session, sir. I'm a practitioner and I'm so thankful for a good session to all the students and the clinicians. Thank you so much, sir.
it's my pleasure, ma'am. It's my pleasure.
Haji, Haji, are you there?
Ma'am, he's conducting the technical issues, so he won't be able, I think, to talk.
Okay, from team members, anybody can talk.
Sir, indeed, it was a wonderful session, and we look forward for the practical session as many of the delegates have requested also, and we would like to keep the session, sir. Thank you, sir.
Ma'am President, do send me the feedback. That is more important for me.
Yes, sir, definitely, sir.
I'll be
I would
looking
ask,
forward.
yes, sir, yes. I would request Dr. Renuka to go forward.
Thank you so much, Dr. Shweta. Good evening, everyone. Myself, Dr. Renuka Deshpande, Vice President at the Cornerstone All India Student Organization. I would like to take a minute to mention about our organization to you, sir. The organization by the name Cornerstone All India Student Organization, as it goes now, was established by our founder, Dr. Suchita Golar ma'am, assisted by our national advisor, Dr. Rajesh Sange, and international advisor, Dr. Mahendra Yadav, in the month of June, with our first event by ma'am herself, along with a speaker from South Africa, Dr. Barry Gates, sir, on how to boost immunity and cope up with this pandemic situation. Since then, Dr. Golar ma'am, along with our advisors and team's efforts, have executed 11 individual and series of such webinars on different topics requested by the students. as she believes and always tells us that this organization is for the student and by the students. We are very proud to be a part of this organization, and thank you all for joining us here and sharing the valuable knowledge on the topic. We look forward for more such events with you as a speaker and consistent guidance. Thank you so much, everyone. And thank you so much, Dr. Vivek Chauhan, sir.
Ma'am, should I go forward with a formal vote of thanks?
Yes, please. Yes.
Hello, sir. Good evening, all. What a wonderful interactive session it was with sir. As all good things come to an end in life, so is this webinar. So on the behalf of Cornerstone All India Student Organization, I, Dr. Prachi Singhi, take this opportunity to give a hearty vote of thanks to sir. Firstly, I thank our resource person, Dr. Vivek Chauhan, sir, for gracing today's webinar. Thank you, sir, for enlightening us with your knowledge and telling us all about low back pain, how to do the assessment, all the outcome measures that we can take, and some exercises that are helpful. So thank you so much, sir, for it. I would also like to express a profound gratitude to Dr. Sucheta ma'am, Dr. Rajesh sir, and Mahendra sir for their constant motivation, moral support, and guidance. A special thanks to our organizing team members for their efforts and coordination to make this session successful. My heartfelt thanks to the delegates for the active participation and to make this webinar interesting also. Once again, thank you all. See you all until next time. Thank you, sir.
So thank you, Dr. Chauhan. God bless you all. And yes, soon we will conduct another webinar of yours. So till then, bye, take care, stay safe.
Thank you. It's an honor to be all with you. It's an honor, ma'am. Thank you. Thank you for inviting.
And yes, thank you to Dr. Mahendra, Dr. Rajesh, and yes, and all the team members. Yes, and all the participants. Thanks a lot for joining.
Thank you. Bye bye. Good night.
Bye. Bye.
Bye. Bye, sir. Bye. Safe Akura. Bye.
All the best.
Bye.
Stay safe.
Bye. Sir.
Bye. Bye.
Bye. Bye. Okay. Hello, Fakur, you know how to mute.
I know.
You know everything, huh?
You don't know.
Chua da. Ella leave the meeting. Ella leave the meeting.